Our next speaker is Dr. Umut Gurkan. He is from Warren E. Roop, Associate Professor at Case Western Reserve University, Cleveland. He's going to talk on progress in diagnosis of sickle cell disease. Over to you.
Thank you very much. Let me share my screen. Okay, you can see my screen, right?
Yes, sir.
Thank you very much. Thank you for inviting me here. It is such a pleasure to be with you today. I wish I could be there in person. I have traveled to India quite a few times, and it's one of my favorite places to go in the world. And I enjoy the food in India, you know, the companionship, the hospitality, and I hope I can travel there soon towards the end of this pandemic. Today, I would like to talk about progress in diagnosis of sickle cell disease. I'm the Warren E. Rapp Associate Professor at Case Western Reserve University, and I have been working with HemexHealth and HemexDx to translate and commercialize affordable, accessible diagnostics for sickle cell disease. I would like to start by saying that we are actually in a new and a very exciting era for sickle cell disease. There are so many things happening. There are new drugs that are coming into the market. For example, Novartis has recently received approval for crizanlizumab. It's a P-selectin inhibitor that reduces adhesive events in sickle cell disease. Novartis has also started a partnership in Africa, in Ghana, a public-private partnership to advance the sickle cell treatments by providing affordable hydroxyurea to everyone who is diagnosed. That in the United States, there's a new initiative called Cure Sickle Cell Initiative. And this group of researchers, and I'm a part of that group, we are working on making the cures much more available and feasible and safe and effective for individuals with sickle cell disease. You might have also heard about Bill and Melinda Gates Foundation and NIH joining forces to develop cures for HIV as well as sickle cell disease. These are all very new initiatives that are ongoing, and exciting things are happening. One last initiative that I would like to mention is the NIH Tech Accelerator Challenge, and our team was one of the winners together with HemexHealth to develop non-invasive multiplex diagnostic technologies for sickle cell disease, anemia, and malaria. The unmet need for diagnostics as well as better treatment is recognized by all the leaders. And I already heard in the previous talks about the diagnostics, the importance of diagnostics and newborn screening. And this is what I would like to talk about today. As you all know, there are many variants, hemoglobin variants, and sickle variant is one of the most severe ones, and sickle hemoglobin can appear in combination with others. SC, SE, thalassemias, S-beta thal, for example. It is important to keep this in mind. SS is one type of sickle cell disease, but there are other types, and the diagnostic strategies should keep this in mind, and diagnostic technology should be able to ideally differentiate between these hemoglobin variant diseases. One more thing that we should keep in mind is sickle cell disease is an hemolytic anemia. Anemia and sickle cell disease are highly interconnected because sickle red blood cell hemolysis leads to anemia. Anemia and hemolysis can amplify red blood cell sickling due to hypoxia, because anemic blood carries less oxygen, and hypoxia or low oxygen levels is not good for individuals with sickle cell disease because it makes things worse for the red blood cell by increasing sickling. So that's why our approach has always been comprehensive. We would like to be able to identify the variants of sickle cell disease, and ideally we would like to also have an idea about the anemia state. This would help us not only diagnose the disease, but also help manage the disease by providing these really key important information, such as the hemoglobin percentages in blood, total hemoglobin level in blood, and many other things. One more thing that we should keep in mind and remember is that the hemoglobin composition in blood is quite dynamic. In other words, it changes over time. After a baby is born, we are born with fetal hemoglobin. I'm sure you know this better than I do, and there is a reason why we are born with fetal hemoglobin, because it has higher affinity for oxygen and it is more efficient in extracting oxygen from mother's blood before the baby is born. But after the baby is born, fetal hemoglobin, the gamma chain is replaced by the beta chain. That's when the mutations exert their effects. For example, a beta chain mutation, sickle cell disease, becomes apparent after the beta hemoglobin is produced, or the adult hemoglobin is produced after birth. And it takes some time. It takes weeks to months for the adult hemoglobin to become the dominant hemoglobin type in blood. And this is important for us, people developing diagnostic strategies, because high fetal hemoglobin levels at the beginning can be challenging, can make it challenging to detect the presence of the abnormal hemoglobin. For example, if you look at the immediate after birth, you might have high levels of fetal hemoglobin, which might mask the presence of the mutated beta hemoglobin that might be present in these babies. High fetal hemoglobin has a protective role, which is very good, but for diagnostic purposes, it can create challenges for certain diagnostic technologies. For example, the turbidity test may not work when the fetal hemoglobin levels are very high, because fetal hemoglobin prevents sickle hemoglobin from polymerizing or sickling. Another important aspect of this, the hemoglobin composition, is in the context of genetic therapies. I will talk about this in a few minutes. One more very important information that we should keep in mind is that the more fetal hemoglobin a patient has in their red blood cells, better their health outcomes will be. It has been recognized, it was recognized, and actually maybe thanks to the high fetal hemoglobin F persistency, which is, I know that, which is quite common in India, can make the patient much more mild or asymptomatic. So as you know, in certain individuals, there is a mutation that results in higher production of fetal hemoglobin even after birth. Even into adulthood, some people have more fetal hemoglobin in their blood cells, in their red blood cells, than others. And it was recognized that in sickle cell disease, a severe phenotype is associated with sickle hemoglobin containing red blood cells, and very few, maybe some cells containing fetal hemoglobin, and not many others. And this is associated with severe phenotype. But if a patient with sickle cell disease has red blood cells containing more than 10 picogram of fetal hemoglobin per cell, then phenotype becomes moderate. And if you have more cells like that, then it becomes mild or asymptomatic. It may, in many cases, if the fetal hemoglobin production is high, then the patient may not even know, this individual may not even know that they have sickle cell disease, actually. And I'm sure you know all of these things more than I do. And this strategy, this aspect, the fetal hemoglobin composition, and increasing the fetal hemoglobin composition in red blood cell, is one of the gene therapy strategies I will briefly talk about later. As you also know much more than I do, hydroxyurea in sickle cell diseases has been effective, and the main impact of hydroxyurea is increasing, again, the fetal hemoglobin level in blood. And it has many important benefits, as you see here. increased fetal hemoglobin has cellular effects. It makes the red blood cells healthier, reduces hemolysis. It helps with the vascular health as well. So it has many aspects, and it also increases the overall total hemoglobin level in blood. So all these treatments, existing treatments, and all these, even the genetic treatments, require us to have an idea about the hemoglobin level in blood as well as the hemoglobin percentages in blood. So we would want to know how hemoglobin A, F, S are changing in response to therapies. I'm sure you are looking at these parameters to assess the treatment outcomes in patients with sickle cell disease. One more thing that I would like to mention is voxelotor, a new treatment that was approved again recently. And in the HOPE trial, it was shown that this voxelotor, which is actually a more oral medication that is taken once a day, increases oxygen affinity of hemoglobin. So it makes oxygen more difficult to be released from the hemoglobin, sickle hemoglobin, and it has been shown to reduce sickling. And the clinical benefits are still under study, but in the HOPE trial, it was shown that hemoglobin levels increased significantly after patients started using this therapy. It also reduced hemolysis. So again, looking at the hemoglobin level is very important, as you all know, in sickle cell disease, and there are new treatments that are coming out. This is what happens in the case of gene therapies, as you know. So one of the gene therapy approaches is to switch to reversal of the hemoglobin switching to produce fetal hemoglobin. So BCL11A gene, as you may know, is responsible for making the switch. But if you disable that, then the fetal hemoglobin production continues or picks up again, and then the adult hemoglobin production goes down. So it's not possible to achieve 100% fetal hemoglobin production because of many reasons. I'm not going to talk about that, but once we achieve 40, 50, 60% fetal hemoglobin production, for example, after a gene-based therapy or gene-based cure, then you can actually move the patient from a severe phenotype to a mild asymptomatic phenotype, which is considered a cure. And if this switch is done permanently, then it is a permanent cure. Again, here in this case, measuring the hemoglobin level and measuring the hemoglobin composition becomes very important. At the very least, there are many things that we need to look at after a gene-based therapy in terms of efficacy and safety, which our lab and which our group is working on. But at the very least, we would always be curious about what would happen to the hemoglobin composition after a cure like this. So one more thing that I would like to emphasize is, according to WHO, World Health Organization, anemia and measuring hemoglobin level using hematology analyzers, for example, is considered an essential list of diagnostics. So it is in the WHO essential list of diagnostics to measure anemia. Another more recent essential list of diagnostics, according to WHO, is electrophoresis-based hemoglobin variant identification. So electrophoresis was included in the WHO essential list of diagnostics for sickle cell disease, I think back in 2019, 2020, in those quite recently, actually. And Food and Drug Administration here in the United States has approved the electrophoresis for hemoglobin variants, a long time ago. It's one of the standard tests here in the United States, as well as in India, in Africa, in many places. But if you look at a typical hematology lab, for example, in Africa, you would see an anemia test, typically a HemoQ, a point-of-care anemia test, but the electrophoresis test still looks like this, as you see in this picture, a power supply, an electrophoresis, chamber. It's like a lab research device. It doesn't look like a medical device. It still looks like an old-fashioned lab device, and the power supply needs to be plugged in continuously as the test runs, and any power disruptions would negatively affect the test. And you would also need trained personnel, result interpretation, because when you run this electrophoresis test, you would see the bands, but you would have to know what band corresponds to which hemoglobin and so on. So it requires result interpretation, which might have user error issues. And the data management is also an issue here. For example, if you look at the way the data is stored in this hematology lab in Kano, Nigeria, they have a large notebook of all the results for the patients or for the tests that they run, and there is no electronic record keeping system. The results are not accessible on a cloud, for example. I know there is a panel discussion on the management of data using cloud-based systems, which is very important in our opinion. So if you also look at the current hemoglobin testing methods that are in use, thankfully there are quite a few options, and there are new ones that emerged recently, especially on the point of care side. And if you look at in terms of their cost and complexity, you would be familiar with the point of care turbidity sickle cell test, and it has its limitations. I don't need to talk about all the advantages and limitations of these assays. I'm sure you are familiar with them, but in summary, the turbidity sickle cell test, for example, would have challenges with high fetal hemoglobin samples in the case of newborns, and it is also not that sensitive or specific. There are more recently developed point of care lateral flow or dipstick based assays, and they are good at identifying hemoglobin S, C, and A, but for all the other variants that you might see, for example, SE, S betas, they would not give you any actionable results. So they would work for sickle hemoglobin and maybe C, but they might actually miss many other variants. Again, these tests require user interpretation. A user still needs to look at the presence or absence of bands or the turbidity, for example, in the case of turbidity test. And in the case of more complexity, like lab-based tests, central lab-based tests, hemoglobin electrophoresis, isoelectric focusing based, is quite useful. This is actually a picture from a lab in Africa that I took when I visited there. And as you may know, these are centralized lab tests. They can really look complicated, and they would need an infrastructure, trained personnel, and the equipment are quite expensive, can be quite expensive in the order of $30,000 or more. HPLC is another lab-based test, centralized lab-based test. Again, it's good for identifying the hemoglobin variants, and it gives you printed results. Again, but not very available, not available in many labs. The ultimate test, as you know, is the genetic testing, PCR based, and these tests are also can be really quite expensive. They are good for for example, maybe confirming a diagnosis for research purposes, but it would be difficult to implement any of these methods for large scale screening programs, especially when the newborns are involved. So looking at the landscape, and we have been working in this area for quite a few years now, we wanted to develop something that has all the advantages of the existing test, and we also wanted to add and address the limitations and the challenges, and develop a test that is ideal for sickle cell screening and as well as monitoring, not only for screening and initial diagnosis, but we also want this test to be used for monitoring the disease, for example, anemia state or the total hemoglobin level or the hemoglobin composition. So we wanted to have a quantitative test. So as I mentioned earlier, electrophoresis is a widely accepted, trusted, WHO listed test and FDA approved. So this is a very good technology to start with. So what we thought was, can we make electrophoresis, can we address the challenges of electrophoresis, but build on its strengths, use the advantages of electrophoresis, but can we address some of the challenges with a better diagnostic platform? And that's how we developed the Gazelle together with Hemex. So we wanted to achieve an affordable point of care microchip electrophoresis based test that has integrated buffers, so you don't really need to have a large setup with the additional buffers that typically comes, large buffer volumes that comes with electrophoresis setup. We added an integrated calibrator that helps confirm that the test is running properly, also helps us make it quantitative, especially for anemia. I will talk about that later. There's no need for any staining, so the steps or the technician or the user interference or user processes are minimized. It takes less than 8 minutes to complete, and it would work anywhere by anyone, and it is quantitative. Two important aspects of this test is we added a quantitative feature, so we can quantify the relative ratio of the bands, which makes the hemoglobin percentage quantification possible. But we also recently added the total hemoglobin level quantification to the test. So different from what standard electrophoresis does, it has many technical differences, but it also produces different results. Quantitative, automated quantitative results, automated recognition of the band. So the user doesn't really need to make any interpretation. The machine learning, artificial intelligence-based algorithms in the device does all the interpretation and quantification for the user. So as you may know, the standard cellulose acetate-based electrophoresis results typically looks like this. So here is a control lane with hemoglobins A, F, S, and C identified. And these four different samples show different bands, and the user needs to look at the relative intensity and the locations of these bands to come up with a diagnostic decision. For example, band 3 is an AC hemoglobin C carrier. Band 4 is an AS sickle cell trait. The band 2 is CC, hemoglobin CC, and band 1 is an hemoglobin SS, probably a child who still has fetal hemoglobin, or it could even be high fetal hemoglobin F persistency, or this could even be someone who is on hydroxyurea, which produces really high levels of fetal hemoglobin. So this interpretation needs to be done, but as you can see, these test results are not quantitative. So what we wanted to achieve is take the electrophoresis platform and make it much more user-friendly and make it much more interactive. Even, for example, the hemoglobin separation and the way the hemoglobin electrophoresis test runs can be observed on the screen of the device as it happens, and then you can see the bands. And then a computer vision based algorithm identifies the pattern, the travel pattern of these bands in relation to the blue marker, and then comes up with a diagnostic decision. I will actually show a video that explains better how the test works in that regard. So in addition to all these advancements in the electrophoresis technology, we also wanted to have a battery operated system which would run on battery all day, and it would work with disposable cartridges. And the team is now working on adding features such that even the lateral flow assays could be imaged and analyzed and run on these devices. The device works, the platform works in high heat, high humidity environments, and the test results are quite fast for the different type of tests that the device has. High accuracy, and it is affordable. It has cloud storage, so all the data can be stored in a cloud and can be accessible from anywhere in the world. Because device is Wi-Fi, has Wi-Fi connectivity, it can be charged with a mobile phone charger. A micro USB charger is all it needs. And then it also has wireless report printing. It can connect to printers wirelessly and print reports. So I would like to now show you a video that explains how the test works, how the device looks, and I will continue after that.
The Gazelle HB variant test is an automated point-of-care electrophoresis platform. It is an automated microchip electrophoresis process inside a miniature cartridge. An electric field applied to wet paper will separate hemoglobin types by charge in reference to a marker dye. While the reader images the paper, interprets the images, and reports a clinical indication in 8 minutes. There are 3 simple steps to prepare the sample for the test. First, mix the sample by pipetting patient blood and blue marker fluid. Second, vortex the mixture to release the hemoglobin. Third, use a provided stamper to apply the sample to the cartridge. Wet the paper in the cartridge by a pipetting buffer in the hole above the stamping slot. Insert the stamper in the cartridge to apply the vortex sample to the paper. Hemoglobin variants have different negative charges. In an electric field, they will migrate at different speeds. A camera records images of the moving bands. The built-in computer compares these to known HB variant patterns. As the electric field is turned on, the sample and the blue reference marker start to migrate away from the negative electrode. See how different hemoglobin variants migrate at different speeds. After the reference dye moves off the paper, the system calculates the densities and locations of the bands on the paper, and the built-in AI determines the suggested interpretation. The quantitative results are presented along with the interpretation on the reader screen and stored in a report. That report can be printed right there for the patient or uploaded to the cloud. Gazelle brings fast, convenient, accurate results for sickle cell and quantifies other hemoglobin types like HBE, HBF, and HBC by electrophoresis to any lab along with complete documentation and traceability as per good lab practice.
Okay, now let me continue. So in addition to the sickle cell disease and hemoglobin test, the same platform can also do many other tests. So the device, the platform, the system was designed as a platform to allow addition of many other tests. Currently, regulatory approval is present for sickle cell disease and trait, also in newborns. Malaria testing is possible on the right-hand side on a different cartridge on the same system. And what we are working on, what my lab is working on together with Hemex Health is to add thalassemia testing, which is essentially an update on the algorithm that identifies the bands and some differences in some updates in the imaging that we need to do. Anemia testing is what we are working on, so it will be added to the platform soon. A1C testing is another project that we are working on. So all these projects are supported by NIH here, National Institutes of Health, and we have projects and grants to develop these additional capabilities. On the malaria cartridge side, we are working on malaria test is already regulatory approved. We are actually trying to have, working to have an anemia test that is integrated with the malaria. So you would get the malaria test result and anemia result at the same time in this test. And another really exciting direction that we are taking is adding fluorescent and lateral flow immunoassays to the same platform. And we have very good results for COVID-19 testing, for example. And we are also working on developing serum protein tests on the same platform for metabolic diseases and even certain cancers. And there are other projects on hepatitis B, C, and infectious diseases. So this platform will be expanded in the coming years to have all these different test capabilities. The existing regulatory approved indications were clinically validated across the world in many places in the world, as you can see here. So this is not a product that was developed in the United States and exported. So this technology was developed in coordination and in collaboration with many researchers in India, and as you may know, the company has an HemexDx component in India, and the manufacturing is done in India, and it is a made in India product. And many of the aspects in the product were developed together with the engineers, researchers, and our really good friends in India. The same is true for Africa and in Africa and Southeast Asia, Thailand. So as you may know, in Africa, in Southeast Asia, there are other variants that are important and present. And we wanted to have a more comprehensive test that would work anywhere in the world for both hemoglobin variant testing as well as malaria. The results of these studies were published in journal articles. There are many of them. I'm just showing you one of them because we were on the cover of Analyst Journal. It's a reputable journal in the field of diagnostics and biosensing, and in collaboration with researchers in India, actually a NERT in Madhya Pradesh in Jabalpur. We actually performed studies there, clinical validation studies in Africa, Thailand. As you can see, there are authors on this paper from all around the world that actually helped us clinically validate the technology, which was published in 2020. And as you know, Gazelle is also available in India through HemexDx, and you can actually see an example of the user manual for users in India. And there are many exciting activities happening in India because it's as I said earlier, it's a made in India product, and it is owned by Indian engineers and physicians and users more than anyone else in the world, actually. So I would like to now share with you an exciting new feature that we are working on adding. It will be available very soon, which is total hemoglobin or anemia diagnostics on the same platform within the same test. So what we are doing here in this case is, if you perform the full electrophoresis for 8 minutes, then you would see the full separation of the bands. And this helps us diagnose, for example, hemoglobin variants, determine the level of fetal hemoglobin, sickle hemoglobin, and so on. So this is already available everywhere. What we have discovered is that with the help of the standard calibrator, the blue band, if we perform a data analysis, this is a machine learning based data analysis. If we perform a data analysis 2 minutes into the test, we can accurately quantify the total hemoglobin relative to the intensity and amount of standard calibrator in the sample. And it actually works very well. Here are some results on how the hemoglobin level identification or anemia identification works in comparison to complete blood count. It's the reference standard test for us. The correlation is more than 95%, which is very good. And according to blend analysis, there is a small bias, about 0.10 grams per deciliter, which is a negligible bias. There is a almost perfect limit of agreement, and mean error is very small. And the accuracy, according to receiver operator curve, has more than 99% for the ROC curve, and the sensitivity is 100%, specificity is 92%, and more than 90% actually. And if this algorithm can also achieve anemia versus non-anemia identification, as well as determine the severity of anemia, mild, moderate, severe, very accurately. Anemia versus non-anemia identification can be achieved with 100% accuracy, and the mild, moderate, severe, as you can see, 196, 100%, so pretty accurate to determine that. On the same test, on the same anemia test, you can also achieve hemoglobin SS diagnosis, SC diagnosis, and AA. We only show 3 examples here with 100% accuracy. So the same test gives you the anemia state, quantitative hemoglobin levels, and percentage of hemoglobin types in the blood, all very accurately and high sensitivity and specificity. One more aspect of this platform is its connectivity. It's one of the very few fully connected point of care diagnostic platforms in the world. So it stores data. It can store thousands of results on the platform. But if it has Wi-Fi connectivity, for example, it can upload the results to a cloud, and these results could be immediately accessible to healthcare administrators or healthcare providers, to the patient. We actually have a project that's ongoing, supported by Vodafone America's Foundation in Africa. We are actually working on making the results immediately accessible to the patient, for example, on mobile phone apps, to the caregivers on tablets and apps. So we would like to generate the results using this platform and make it available and accessible to anyone who needs to have access to that. And this project is also supported by NIH and Vodafone, as I mentioned earlier. So I would like to thank the team members at Hemex Health. I'm an inventor and a researcher in the group, but there are so many other business experts and with people who have experience in developing medical products for global health applications. And Purnima, for example, our managing director at HemexDx, our local connections in India, Africa, anywhere in the world have been really the key and the really strategic, the essential piece of our team in making these products available and accessible. I also would like to thank all the supports that we received over the years from many companies and the organizations. Tata Elixir is shown here. They helped us actually with the initial product design and also market research in India and so on. And there are many others, as you can see here. And I would like to thank you for your attention. I would be happy to have answered any questions that you may have. Thank you very much for having me today.
Thank you very much, Umut. There is a question, what is its cost in India?
Yes, so unfortunately, I don't really have those numbers because, as I said, I'm a researcher. I'm not really familiar with the distributor. The distributors are actually handling those things, and we would be happy to follow up and put you in touch with the distributor or our HemexDx representatives. I'm sorry, but I don't have that information.
Thank you very much. We'll follow up on that.
Yes, please.
That another very interesting thing which has come up is that one of our medical students, Simran, is asking how can the medical students help in disseminating the knowledge or in this mission of reducing sickle cell disease. That's a very heartening thing. And I think we will, when we are making the program for the whole country, we will take into consideration that medical students are an area which we need to tap into, and perhaps we can, help us in disseminating the information and act as force multipliers for our mission. Thank you very much. Thank you very much, organizers, for giving us this opportunity. And over to the organizers, please.
Thank you very much.
Dr. Prashant, would you like to take this question regarding the cost?
Yeah, definitely. So actually, the instrument cost is something around 90,000 to 1 lakh rupees, and the test cost could range something around 160 to 180 rupees. But the respective distributors, because the Hemex, though I'm heading Hemex here in India, but we do operate to the distributors. So I will be happy to, be touch base with the one who are interested in this particularly product line. But this is the tentative cost, the cost of the instrument and cost of test per test.
So
something around 160.
Thank you, Dr. Prashant. So for the interest of audience, those who are interested or have a query about the equipment and the test, they can put their request with their contact details, email and mobile number. We can pass on that information to Hemex team. I hope that is okay. I am pleased to invite Dr. Prashant Khadke, Vice President Commercial, Hemex Health, for the panel discussion and also enlighten us on the cloud solution you have. Dr. Prashant, please.
Yeah. Thank you so much. Thank you, Rajesh. Good evening all. Good evening, everyone. First of all, I'm really thankful to the organizer for organizing such a fruitful event from last 2.5 hours. It's really brainstorming session, and good to have such a session. time, last 1.5 years, we are really struggling to get back to the normal. So thank you so much. So as we know that tomorrow we'll be celebrating Sickle Cell Day. So this is the Sickle Cell Conference. So it's a pleasure to me to be here to represent the Hemex Health, and thanks to Dr. Umut Gurkan, who has already, told you we have in the market, particularly for the sickle cell, thalassemia, and malaria. So just to start with, my name is Dr. Prashant Khadke. I am a Vice President Commercial and Operations for the Hemex Health here in India. So I will be moderating today's panel discussion. So about Hemex Health is a innovative company who is in particularly in point of care instrument and solutions manufacturing. So truly we are make in India or made in India product. So we have innovative point of care ultra portable unit which can be hand carried into the tribal areas, and which has a GPS system, which has a cloud system for the digital health record, which is battery operated. All these features has been very well discussed by Dr. Umut. So I will not, just in the interest of the time, I will move to exactly to the topic. So let me introduce today with our honorable panelists. Those who are already a subject expert. So basically, just for a formality, I would like to introduce them, but they are already very well renowned and well known to the sickle cell scientific and the diagnostics fraternity. So I would like to start with Dr. Prakash Pangam. So he himself is the icon, very fatherly figure, in sickle cell. So Dr. Prakash Pangam is a professor, holds a postgraduate degree in hematology, and currently is the CEO of the Parent Association Thalassemia Unit Trust Center in Nashik. He is also ex-regional director for AIILSG Nashik Center, ex-in charge of hematology laboratory at hospital, Mumbai. It's a very honor to let you know that he has organized more than 1,000 sickle cell anemia, thalassemia, and blood group detection camps in Maharashtra and across India, and he has many awards in his credits from the government, state government, and government of India. So welcome, sir. Great to have today for this discussion. Welcome, Dr. Prakash Pangam, sir. Our next panelist is Dr. Anita Nadkarni. She is the Deputy Director at National Institute of Research Experience in the field of molecular biology and genetics, with the specialization of molecular genetics and hemoglobinopathies. She has published more than 130 papers in international and national reputed journals. And she is also recipient of National Award of ICMR, BGRC Silver Jubilee Award in year 2012. Welcome, ma'am. Pleasure to have you in today's panel discussion. So next we have Dr. Tulika Seth. She is the professor at AIIMS Delhi and clinical hemato-oncologist by training, have a distinguished academic career with more than 160 research papers in various international and national journals. She harbors a keen interest in preventive medicine and public health. She has several completed and several ongoing research projects funded by national and international funding agencies. She has major work involving the studies of genetic and non-genetic factors affecting treatment of outcomes in hematological malignancies, aplastic anemia, platelet disorders, and bone marrow transport. Thank you, ma'am. Pleasure to have you in today's discussion. So overall, I again welcome all the eminent panelists today. So as today, tomorrow we'll be celebrating Sickle Cell Day, and we know year 2020 started with a panic moment of COVID-19 pandemic. From last 18 months, not only India but entire globe is struggling because of the the heavy pressure or heavy workload on the entire healthcare systems. But we should not forget that along with the COVID, WH has also given a red alert, particularly not to overlook or not to neglect for the other infectious diseases, particularly if you look at the immunization, other diseases like tuberculosis, like malaria, and sickle cell is one of one disease amongst that. If you look at in past in 2009 H1N1 pandemic, at that time also it was revealed that particularly the virus related complications were much more with the kids or with the persons having the sickle cell. So this clearly indicates that we really need to focus on other important diseases along with the COVID, not only the COVID. So other things should not be neglected. And as we know that sickle cell is not curable, so prevention is better than cure, particularly in this. And as we know the 3 T's because of the COVID, that is tracing, testing, and treatment. So particularly the early diagnosis really important, particularly for the sickle cell. That is for that tracing is important and testing is important. So despite of many sickle cell successful programs, which has been told by the earlier eminent speakers, we know that still we are facing a lot of challenges. The challenges are like, still the unreliability of solubility test, basically, the demographical, the limitations. We are not able to go to the rural areas or the tribal areas. And Dr. Vinita Shrivastava, I'm really thankful to her that she has really pinpointed the pinpoints, right? She has given a very good example of the scanty data. And whenever I'm discussing with the researchers or the various doctors, they do agree that yes, particularly for diseases like sickle cell and anemia and thalassemia, anemia, the scanty data is a major challenge. And I do believe that in today's panel discussion, we'll be touch base with that how the cloud computing, how a solution like Hemex will help to have really a good process data. Then particularly the maintenance of sickle cell disease records, the patient records, and most important, I personally feel that request all the panelists to have their great opinion. Particularly, can we have some registry for the sickle cell disease, the official registry at a national level, at a state level, because where we can get authenticate data district-wise, state-wise, which will help us, government and the central government, to allocate the resources and efficient use of resources, how it is important we have seen during the COVID time. So, rather than, just discussing all these things, because it has been, discussed from last 2.5 hours, I would like to start actual topic. The actual topic is screening and surveillance of sickle cell disease in India, and need to be a cloud-based system for patient and disease tracking. So definitely I will like to start with Dr. Pangam sir, and just want to ask him a question that he has a good experience working in the tribal areas or the rural areas while arranging such a huge number of the camps. So sir, may I know your experience, that what are the challenges being faced during the screening and surveillance of sickle cell disease in India?
First of all, thank you for giving the opportunity. And Dr. Anita, Dr. Tulika, I am very much happy because after 40 years servicing in hematology in Nayar Hospital with all topmost hematologists, and then doing this camp. But when doing the camp, we are doing the thalassemia checkup. But during the thalassemia checkup, we are detecting the sickle cells. And it is started from 1980. So that time there was no automation. We are doing the old methods, CBC, retic count, and all these things. So it is not possible to rural area doing all these things. So what we are doing, we are going there, collecting the samples and doing the camp. But nowadays, after 40 years experience, what I told Prashant, first, when I go to the rural area, there is they don't know about the thalassemia T or sickle cell. So first we have to aware these people, and then we can do all the things. That is one first point come in my mind. And second thing is, new techniques what coming research, if it is helpful for us, then it is very good to do these things. And third, not only the camp, nowadays what happened, they're doing the only camp, but no recording. So record has to be done. And when the thalassemia patient, we are doing the student, I am not handling the patient anything, we are doing the student. So what we are doing, when the student come positive, whole family has to be studied and keep the record. So that work at present, last 10 years I am doing it. If the student comes sickle positive, has to do the family study, keep the record. And this record, everywhere, whatever the people who are doing this camp, has to keep the record, and that make a complete computerized this one, what Prashant has said. And madam, second thing I want both of you, because you are clinically handling, I am handling only the laboratory side of this one. So this one is not only the reporting and giving the, you should give them that further awareness. And suppose they are the young, before marriage, what they have to take the precaution. This is the most important thing when I am doing the camp. So Prashant, what I want to bring their awareness, then record, and then keep recording all the state-wise for this sickle cell disease.
Great. Thank you so much,
Yes,
sir.
Prashant? Yeah.
Thank you so much, sir. Thanks for your inputs.
One
May I
point,
ask? Yeah, please.
One point
Please,
I want
please
to add
go
here,
ahead.
madam. Yeah, one point I have to add here. When you detect students positive, without family study, we cannot give the report, because one case come in my case like this. Student was positive, but the father and mother was negative. So in thalassemia or sickle, it is not possible. But when I take the interview, so that wife was second wife. So first wife expired with the disease. So this is the main point why we are to do the family study. That point I want to mention here.
Thank you so much, sir.
Yes,
because
continue.
the real field experience is really different than what we always see theoretically. So your real field experience will definitely help us. So may I ask Dr. Tulika, you want to add on this? Any challenges we have faced in the past, particularly for the sickle cell screening?
So Vinita ji had sent us a few years ago, before COVID, to some districts for training. And in many of the districts where we had gone, they didn't have diagnosis of sickle cell patients. But when we talked about the different presentation of the patients, they would say, oh yes, we see lots of patients like this. And then we found out that the HPLC was not available in many of the smaller districts, which is one of the reasons why Vinita ji is working very hard. Now, we all know that the solubility test is a screening test, but again, you have to be very meticulous and you have to know how to do it, and you have to do it in proper controlled environment. So these tests often work very well in a laboratory, but sometimes in the field where you have lots of issues and where people are not very well trained, they're not very useful. So I think a point of care test that is very reliable and reproducible is actually the need of the hour, because you cannot have HPLCs running in every remote district. Again, you need trained manpower, you need all the reagents, you need a lot of things for HPLC. So I'm actually very excited about what you're talking about, the point of care test. So that's really, really important. The second thing is that you're talking about the data. So again, you have to thank Vinita Srivastava for this, because we have now started a program where there will be integrated centers for hemophilia and hemoglobinopathies, which will obviously include sickle cell. And these are going to be set up in every district of the country. Unfortunately, because of COVID, we haven't reached the target, but Vinita ji's done almost 100 of these. But of course, we have a huge country, so there are still many more to be set up. And through the e-Rakt Kosh and the database at the Integrated Center of Hemoglobinopathies and Hemophilia, there will be data available at the district. And this district data is very important because it will tell the hospital how many patients they have, how much medicines they need, how much blood supply they need. Many things are going to be required. And once we have the actual data, because the number of patients we've identified is actually very small. And if we have 14 lakh patients in our country, there is a large number of patients who we haven't been able to identify. So a lot of things are moving towards the same direction. And I think hopefully as soon as COVID kinds of settles down, we will get back on track, because we need to be able to get this data in order to plan for the future.
Thank you. Thank you, ma'am. Thank you so much for your insights. So definitely my next question is to Dr. Anita Nadkarni. So ma'am, as we have seen, most of the speakers were talking about newborn sickle cell screening. Okay. As earlier it was not included in the guidelines, but right now, most of the state government, even central government, Dr. Vinita has also talked about NBS screening. So do you think that newborn screening should be made mandatory at the hospitals and the nursing homes, especially in STD prevalent, tribal and rural areas? Because you have a great contribution in a neonatal and newborn screening research work. So please guide us, ma'am.
Yeah, actually, I think it is must and mandatory, because we started a very first newborn screening program way back in 2008. In Central India, that we did with Dr. Dipti Jain. And at that time we have used the targeted screening, like we have first done the antenatal screening, positive mothers, babies we have screened, and about 2000 newborn screening we have done that time. Then second newborn screening program we carried out in 2012 to 2015. That was in Gujarat and Madhya Pradesh. And now at the moment we are having a big newborn screening program on 7 states we have included. And up till now we have screened about more than 13,000 babies. And in our experience in this newborn program, if you give a proper comprehensive care, you can really reduce the morbidity and mortality. And all these newborns which we have screened, we have followed it for nearly 3 to 4 years. And later on, we have looked at it, and we came to know that about usually the deaths are usually happens before 2 years of age in tribal and rural areas. So with my experience, the newborn screening program should be initiated in each and every district. And like many people have made the antenatal screening compulsory, the newborn screening should be made compulsory, at least in the areas, tribal areas, where sickle cell percentage is very high. And talking about the data, what you were saying, actually, I just wanted to share that ICMR had started with the National Registry for hemoglobinopathies. Yeah. And in that, we are at the moment putting all the sickle cell, all thalassemia patients entry in that. And I think we have already had a talk with Vinita madam that NHM, this thing also can be integrated, and we can have a registry of hemoglobinopathies for whole India. So that will be a really good initiative.
Yeah. So actually, as we say, prevention is better than cure, and for that, tracing is really important for disease, because this disease is not exclusively in metro cities or where the facilities are available. We really need to go to the tribal areas. Sometimes there are no road facilities. I have very short experience working in the tribal part of the Nasik or the Dhulia districts in my past. So I understand the limitations over there. So when we say newborn screening should be a must, so definitely the tracing of the newborn screen babies along with their family is essential part. And for that, our honorable minister, Prime Minister Narendra Modi ji, now he has already launched, the digital health or the India campaign. And for that, the EHR nowadays, the electronic health record, that is maybe a very soon could be a reality in India. And let us start with this. So my next question to you all, one by one, because in the interest of the time, I have to, also respect time. So with the introduction of National Digital Health Mission, India is actually, progressing towards medical health record, EMR or EHR. And, we really want automation into that. And, as Dr. Vinita also said that, because I personally believe beauty of science lies in its simplicity. So we should simplify the science. So even ASHA workers should also handle some automation. So say, for example, instrument like a Gazelle, which Dr. Umut told, particularly for the Hemex, can be handled by the ASHA workers also, because they need not to write anything, everything, the data uploaded can be, visualized with high encryption by the government authorities only, and it is one-sided only. So it is a highly protected one. So if you really want to create some national database for the sickle cell patient along with their location, because it is a GPS enabled, so automatically we will able to know where that particular patient got diagnosed. No need to manipulate the data, and accordingly the resources can be allocated. So do you really think, looking at the experience last several decades, we are working on sickle cell, thalassemia, and all other things, so such a surveillance systems could really help going to the next level, particularly for management of particularly disease like a sickle cell. So I really want your thought one by one. So can we start with Dr. Pangam, sir, please?
Yes, sir. Exactly your point. Because what we have done in Jalgaon, ASHA people means and Anganwadi, we have trained them first to collect the record of each and every houses, and there we have got 1 or 2% sickle and thalassemia children already detected, but they are not coming out. So what you say the point, even Dr. Anita and Dr. Tulika agree on this point, these people at least for awareness and collecting the data, and that we can put in the our data. So this is my main first. We have to aware them first. We have to educate them. We have done more than 400 Anganwadi ladies and ashas during the COVID period, and that time COVID plus thalassemia and sickle cell, we are given the education. And Dr. Nemade, MD Jalgaon, myself and she work in that area, and really we are successful. Now what the Prashant said and both of you accepted, we have to record it in computer. This is my opinion personally.
Okay, thank you, sir. Thank you. Dr. Tulika, you would like to add your remark on this, please?
So I think having a cloud-based data for patients would be absolutely wonderful. We obviously in Delhi, we don't see a large number of sickle cell patients, but we get patients who are referred from all over the country when they have complications or they have major problems. And many times they come with no medical records, or they have just very scanty information. So we don't know what treatment they've been receiving, how they've responded to the treatment, what complications they had. And having a cloud-based thing would really make it easy for the patient and for us who are treating, because then we would have all the information which we can then use to help the patient. So information is really, really power, and the more information we have, the better. The only other thing I just wanted to add on the newborn screening, apart from getting the babies into the healthcare system early and preventing complications, the other thing that is being studied all over the world is these families with young children who have been diagnosed with a chronic disease. They need a lot of psychological and psychosocial and other support. And getting this diagnosed early helps them to get access to this other information. Otherwise, they have a sick child. Nobody knows what the problem is. And these families with young children are also young parents, and they don't get the access and support they need. So along with, I think, the wonderful work that Dr. Pangam is doing, I hope he can also help along with the rest of the system to improve the psychosocial support for these patients and families.
Thank you, ma'am. Dr. Anita, you would like to add some concluding remark on this?
Yeah, I think having a cloud-based data is really an excellent idea. But I myself have worked in the field areas in sickle cell anemia. So it is more important to know how you will establish that system, like getting the Anganwadi workers, ASHA workers, because many times it's become difficult for us to train them and at least get the information from the each and every household, especially from newborn screening, the house deliveries and all that. So it's a good idea, but you should see the way you will work it out. It will be really difficult, especially I'm talking about sickle cell anemia. If it was, because it is mainly concentrated 80 to 90% in tribal area, that too very interior in the central India. So having it, it's a good idea. And if you succeed in that, really, I will be the happiest person to help you out in that.
No, definitely, and we'll be seeking your guidance and support into that. Thank you so much. So in the interest of the time, definitely we would like to go to the audience for some questions. But Rajesh, I think, I don't know whether the time permits to us, because, there are many, eminent speakers are in queue. So I do not want to delay, because everything is really going nice from the start. So I really want to respect not my, but everyone's time. We have a lot of things to be there. So thank you so much. Thank you so much, Dr. Pangam, Dr. Tulika, Dr. Nadkarni. I'm really, grateful to you for sparing your valuable time. Thank you, Rajesh, particularly for giving this opportunity to have a brainstorming with such a eminent, scientists, researchers, and doctors, clinicians around. Thank you so much.